other question now, we can advise patients on what to do in terms of protecting themselves, protecting their family. But one of the difficulties that the patients really come to us for are treatment. They want to know whether or not they're going to get better, but they also want to know what we can do to help. Well, the truth is, because of the difficulties in doing the research, the best treatment for smell loss right now is really time. With the passage of time, people generally get better. And Beverly has hinted at this by saying basically that there is a remarkable regenerative capacity for the sense of smell. I will say, though, that the human sense of smell doesn't enjoy nearly the capacity that other animal species do. Other animals can't survive without their sense of smell, so they have an incredibly robust regenerative function. As humans, we've lost some of that regenerative function. In fact, when we look at the data from our center, what we see is that there is improved function in really not that high a percentage of folks who suffer an acute sensory neural smell loss. Folks with upper respiratory infections only recover 50% of the time at least some smell function. The other 50% of the time, they're essentially still anosmic, and they really don't recover any of their function in terms of their sense of smell. And for head trauma, the statistics are generally worse. In head trauma, only 1 out of 5 people will have any substantial recovery from a total loss of sense of smell. So even though time can help to heal some of the wounds, it's not necessarily the answer. So what are some of the other things that are out there? What are some of the other treatments in terms of smell loss? Well, the classic treatment, which we see every week in the clinic, is someone is trying zinc for their loss of sense of smell. And this is something that was popularized in the 60s and 70s, but basically there has never been a study that has been done that actually shows that taking zinc will improve your sense of smell once you've suffered a smell deficit. There have also been studies that have been published that are one-off studies, so to speak. They have one small study that has shown a bit of improvement. These are studies that have been done with minocycline and with alpha-lipoic acid. And unfortunately, those studies have also not been replicated. So in a number of different centers, when alpha-lipoic acid has been given to patients who have lost their sense of smell, they haven't had any improvement. And as I said, some of the problem is really getting to the patients soon enough. But in general, these are the things that people are trying but really haven't been effective. What may work? Well, there have been a lot of studies done in terms of nerve regeneration with glucocorticoids. So high doses of steroids, given intravenously or given orally, have been shown to help in injuries to the spinal cord and in other neurodegenerative type of illnesses. So logically, if one can give high-dose steroids at the time of the smell insult, at the time of the viral infection, potentially you can have a benefit. There have been some studies that have looked at giving oral steroids to patients, but unfortunately those studies are actually confounded by not knowing the exact etiology. When the etiology tends to be polyposis or nasal sinus disease, there tends to be a substantial recovery. But for pure viral loss, we're not so sure that that's going to be effective. Nonetheless, when we have patients that present early on with their loss of sense of smell, I favor giving oral medications, oral glucocorticoids, in order to try to jumpstart the sense of smell, so to speak. I also have patients that have lost their sense of smell and then are regaining their sense of smell. And in those patients, anecdotally, when they have a cold after having already a smell loss and starting to recover, we give them glucocorticoids in order to treat that, to try to prevent another drop or another insult to the smell system. We don't have good data to show that that's effective, but it makes sense. There are some researchers that have also talked about giving theophylline and pentoxifylline, these medications, in order to restore the sense of smell. The jury is still out. It's really only one center that has had success, Dr. Henkin and his colleagues, in terms of treating individuals with theophylline. And currently, he has been using intranasal theophylline and has had some success, but with very small numbers of patients, 10 to 12 in the published studies. So perhaps this may have a future. What we have looked at Monell is actually the role that vitamin A plays in the loss of sense of smell and the development of smell. And it plays an important role in the embryonic development of the central nervous system and particularly the olfactory pathway. There is also a postnatal differentiation of the olfactory system. In other words, smell is a learned type of sense, just as vision is, and retinoic acid appears to have a benefit or is needed for that to occur. And it also seems to be involved in gene expression in regenerating olfactory neurons in adults. So the recommendation for vitamin A is 4,000 international units in women, 5,000 international units in men. Most individuals do get substantial vitamin A in their diet if they have a balanced diet or if they take a supplement. There is a limit, though, to how much vitamin A you can take. Vitamin A is concentrated in the liver, and one little-known historical fact, Admiral Byrd, on his expedition to the North Pole, everybody on that expedition died. And they died because they ate polar bear liver, which is extraordinarily high in vitamin A, and they basically died from vitamin A poisoning. They never made it, essentially, because of that. So you can't let patients take huge quantities. Vitamin A can't be given in sufficient doses, and pharmacologically, vitamin A is only available as a drug called vesinoid, which is actually reserved for individuals that can't process vitamin A and absorb vitamin A in their diet, and they become vitamin A deficient, and so they need the vesinoid. But in general, we can't give large enough doses to be safe to cause this kind of effect. What we've done is we've told our patients to take beta-carotene each day, and we've told them to take the beta-carotene because the beta-carotene actually at 25,000 units a day is safe, and it will at least maintain what level of retinoic acid is necessary as a cofactor. But we don't have good studies to show that that is effective.